Oh, we're live. Don't talk bad about anybody. There's a screen share here. Present to everyone. All righty.
But I'm finally getting the book.
All right. So, what chapter are we supposed to be through tonight? Just 16, guys. I'm going to probably get through 16. I'm probably going to stop about 7:30, 7:45, so I can get on the road. I think. Well, if it's light out, I'll be fine. And we could get through 16, and probably what's 17 cardiac and. So we'll okay. So we'll definitely get into 16, and then we'll start 17. We'll just kind of get an introduction to 17 and call it good. On general pharmacology, what are you laughing at? On the general pharmacology, I don't know how much. I guess I could just go over the slides, but let's just do that. Man, it does. I probably do.
Let's go.
I was gonna just tell you guys some tips on general pharmacology. Like, it's probably all in there, just to be repeating myself, so I'll just get started. Multimedia directory, oral glucose administration. I'll tell you what. On oral glucose, big thing is you need to make sure they can protect their airway. So they need to be able to swallow or gag or whatever. So they need to be conscious enough that they can protect the airway. If they're drooling, slobbering, if they're unconscious, don't give them oral glucose. I still have people want to shove it under their tongue and bring them back around. You used to do that. We learned that back in 91 or so. But probably in about 2000, they stopped doing that. You stick at the oral glucose on the tongue depressor and put it in their tongue. Relatively safe. You brought people around, but there is a possibility that if it still says
that, but then on the test it says something about if you don't put anything in a person's mouth unless they're
it's a contraindication to put oral glucose in somebody's mouth that can't protect their airway. You could end up with them aspirating that, and then you have a big problem. So, but I still have people that do it, that want to do it. I chew them out every time they do it. So, anyway, please don't do it. We'll go ahead and go over it. So, topics are medications EMTs can administer, general information about medications patients often take, and assisting in IV therapy. One thing that drives me insane is whenever I have staff that says, well, I don't start IV, so I don't even know how to do it. I don't even know anything about it. I don't even know what this stuff is. Most of this stuff, I'm pointing to my shelves here, for those that are listening. Almost everything over on this shelf is IV stuff. And so it drives me insane whenever I have basics that are checking my truck that they say they don't need to check the IV stuff, or after we run a call, they won't stock the IV stuff because they don't know what it is. Well, the thing about it is just because you're a basic and you don't start IVs doesn't mean that you shouldn't know what it is. Because whenever I'm starting IV, if I need help or something like that, let's say we get a combative patient and I need some help, you need to know what it is so you can help me out. The other thing is it just makes you a good partner whenever in this type of service. Now, the type of service I came from in Topeka, where I took care of the back of the truck, my partner took care of the front and everything else in the truck. That type of service, okay, but this type of service is a little different. We're all a team. I'll run a call, they clean up. Well, is it really fair that part of cleanup is restocking the truck? That I ran a call, I did the work, and now they don't know how to restock the truck, and now I got to go restock the truck? Not really. It just kind of makes you, in my opinion, a less valuable team member. So anyway, I'll get off that soapbox now. I feel like it's important that all levels know what every piece of equipment is on that truck. If for anything, to know whenever we get into a really bad call, that I could trust you to grab the right thing for me. So, medications EMTs can administer: aspirin, oral glucose, oxygen, activated charcoal. If they don't have more on here in Oklahoma, you could do albuterol, Atrovent, nasal Narcan. I think that's it. What's that? Yeah. So aspirin is administered to patients with chest pain of suspected cardiac origin. Obviously, always. What's that? Always make sure that that the patient doesn't have a bleeding disorder that would prevent them from being able to take aspirin. Stomach ulcers, things like that. Also, one thing to ask them, because a lot of people know that if they start having chest pain to take aspirin, ask them if they've already, have you already taken aspirin? Well, yeah, I did. Typically, our protocol says to take 324 milligrams. Sometimes at home, I just take 81 milligrams, or sometimes I go ahead and take 324. So ask them how much they've taken. If they've taken the full 324, don't give it to them again. Just document they took it before your arrival. If they've only taken 800 or 81 milligrams, go ahead and give them 3 more of the 81 milligram aspirin to make 324, 5 grains. I believe that's what it is, which is kind of crazy. How does this math even out up? Four aspirin of 81 milligrams is 324. Each aspirin, I believe, is 1 grain, but you give 4 aspirin, it's 5. So anyway, oral glucose. Oral glucose may help patients with diabetes. This is what typically what oral glucose looks like. You just take that little round thing off and squirt it in their mouth. It tastes like really bad sugar or really bad frosting. It's really not all that tasty, but it does a very good job. I'm not sure. I'm sure we'll go over diabetic emergencies, but if you do end up giving oral glucose, don't just say, "All right, you're back with us. See you later." Make sure to give them a sandwich or something so that they have a complex carbohydrate on, so that they don't crash again. This brings it up really fast, but it also comes down their blood sugar comes down really fast. And so you don't want to just give them oral glucose, they come back around and you leave, because most likely they're just going to crash again. So go get them a sandwich, or have their family members make them a sandwich, or some kind of complex carbohydrate. And then make sure that somebody's going to stay with them if they refuse. I've actually, when I was in Wichita, we went and bought a lady groceries because her welfare check hadn't come in yet. She had no food in her house. So we went and bought her a loaf of bread, a stack of cheese, and then like some ham and stuff to get her through. She was poor. And it wasn't like one of those that I'm on welfare and I have a big screen TV. She had nothing in her house. You probably have a big screen TV in your house. You at least have a nice vehicle. She had nothing. We felt bad for her, and we also knew that if we didn't do something, that we're going to be going to her house over and over and over again throughout the week. So we kind of had that off. And selfish, because I didn't want to run the call all the time.
We weren't going to point that out.
So oxygen is a powerful drug. I know that we're getting to a point where we're really limiting oxygen, but I have seen oxygen work. I've had the patient that was in runs of VTAC, which is not a good thing to have happen. With they'd feel funny during it, so they weren't really complaining of chest pain or anything. O2 sat was still pretty good, as 95, 96%, but I went ahead and put them on O2, and the runs of VTAC stopped. So I have seen oxygen actually work and treat somebody. So we didn't have to give them lidocaine or anything like that. We didn't have to consider cardio. I mean, it was very serious. It was like a normal heartbeat, VTAC. Oh, I feel so funny. Normal heartbeat, VTAC. And so it was a pretty serious thing. Put him on oxygen. So he probably had a blockage in the coronary arteries somewhere, and the heart was getting aggravated. And so the oxygen, bringing the oxygen levels up, got enough oxygen that the heart said, okay. I imagine the guy ended up with some stents. Here's activated charcoal. You'll hear everybody tell you that your patient will puke this up. There's a really good chance they will. If you ever taste activated charcoal, it doesn't taste as bad as it looks. It actually, yeah, it just has it kind of has a sweet taste, a sweet charcoal taste to it. Your intentional overdoses will refuse to drink it. Luckily, I have plan A, which is you cooperate, or plan B, I make this happen. And so they usually go with plan A. Yeah, there you go.
I come in and not nurses and little nurses, they put this little hose in their nose, and I said, "Pull that thing out." You just already know, you know, but they, oh, I don't want that. I don't care. You go down there, and they're already know.
Yeah, and the other thing that I threaten is if you spit this up or throw it up,
Oh, yeah.
I will put the tube down your throat and I will give it to you. And you know what? I have never had a person puke it up or spit it up. So yeah, I always threaten them beforehand. I don't give them the chance. Ellen must be nice and didn't threaten them beforehand. But I do. I threaten them beforehand.
They're big and big. Please call ambulance, please.
Bronchodilator inhaler. A prescribed inhaler may help a patient who has respiratory problems. For Oklahoma, and I think probably nationwide, your bronchodilators that you could give off of the truck are albuterol and diazepam. You can assist them with their bronchodilators. Some things to look at, like this lady here has a meter dose inhaler. You'll see it labeled with MDI. A lot of times they'll have an MDI with a chamber on it. They hit the meter dose inhaler and then take a hit, if you will. But the problem that I see a lot of these people do is they don't use it properly. So they take it in their mouth and they blow it out, and that's doing nothing. They need to inhale the meter dose. Yes. And you don't see a lot of people take it correctly. As a matter of fact, a lot of people that you see on albuterol treatment, they'll just be taking little puffs. Whenever I get there, some things you want to look at with albuterol treatment is if they're doing it correctly. When you walk in, you'll see them. I mean, if they're doing it while you walk in, they're coughing. But the other thing that you'll see is they might be tachycardic because and shaky. A little anxious because it is a beta 2 agonist, and so I have to think of the terminology here. So basically, it gives them that opens things up, and so they get kind of this jittery feeling, kicks that heart rate up a little bit, or a lot. So if they're taking it right, you'll see those things. So I wouldn't give them another one. Now, if you go to their house, they said, I've taken my albuterol treatment. Their pulse is 78. You know what? You weren't taking it right. And so then I'll instruct them how to take their albuterol or mine. And if try to. No, you need to inhale it. You need to take a deep breath of that, and then start coughing. I don't like that though. That's what. Yeah, it hurts. That's what is going to help you. You correctly. And the other side of that is if you do go in there and you believe that they're taking it right, you can do. Then you can just move on to Atrovent, or you could do a Duoneb. Duonebs are awesome. They follow your local protocol. Prescribed medications, inhalers, nitroglycerin, and epinephrine. Oh yeah, you guys can do epi. You guys can assist with all of the above. So if they have an EpiPen, you could do or assist them with an EpiPen. You can also use an EpiPen off the truck. I love EpiPens. They're used for if you have somebody that is having a real bad asthma attack or allergies. They'll work great in both those situations. Nitroglycerin, you cannot use it off the truck, but you can assist somebody with their nitroglycerin. There was a big confusion whenever this kind of first came out, and you had EMTs giving nitro. Personally, I don't see what the big deal is. I mean, if we're teaching them to use other drugs, nitro is one that's easily taught how to do. The problem is nitro can bottom out your blood pressure, and at which point in time you guys don't have any way of treating that. So I could see kind of both sides. So typically, if you bottom out the blood pressure, it's because they had a right-sided MI or an inferior MI. And so you can't see that in the 12 lead. I've actually watched providers that don't know how to do a right-sided 12 lead give nitro to the point of killing somebody. And yeah, without changing it. If you're just doing, you actually have the 15 leads and you have 15. That would be a good thing. And, 15 leads are great because you get the whole picture of the heart. And if you have that inferior MI, then you're not dosing with with nitro and bottom their pressure out and killing. You shouldn't be giving nitro to the inferior MI. And a lot of providers don't understand that. They understand if I give nitro and it drops the pressure, I shouldn't give it anymore, but they don't understand why. It has to do with what part of the heart's affected by that MI, and so whenever you drop the pressure like that, you end up killing them. It's that deal. And some of them they'll keep dosing nitro and whoa, stop. Bob Page does an awesome class, and I think we ought to have him come out and do a 12-week EKG class because he talks at a level that us dumb medics understand, but he teaches at a level that he goes to cardiology conferences and teaches cardiologists. He's a paramedic, and so he's a pretty amazing guy when it comes to 12-week EKGs and things like that. And he shows you why, and you all of a sudden you understand it. It's really cool. He's entertaining. Bronchodilator inhalers used in patients with asthma, emphysema, and chronic bronchitis. Enlarges constricted breathing tubes. Side effects: increased heart rate and patient jitteriness. I figured we would have had a medical term rather than just jitteriness. I guess not. We all understand it. Nitroglycerin. Nitro is often prescribed for chest pain. Forms of nitroglycerin include a spray. It also comes in a nitro tab, and it also comes in nitro paste, and then IV nitro, which IV nitro is probably one of the best nitros to use because you could control how you're giving it. This is the meter dose like this is a lot of nitro, and so that's why it can bottom the blood pressure out. If you have IV nitro, we could give very little doses of nitro. Still get the effect we want, but we don't drop that blood pressure, and so you can titrate to effect. What's that?
The pace isn't very good.
Yeah, the pace is terrible. I hate paste because what you do is it's typically 1 inch of nitro paste. You're supposed to take this tube and it's like toothpaste.
Yeah, toothpaste.
and you squirt it out onto this line, and they have this 1-inch mark. Well, how about if my line's fatter than your line, or I squeezed a little harder? You know what I'm? So I agree. I hate nitro paste. The other thing about nitro paste is a mess. And so nitroglycerin taken by patients with a history of chest pain and cardiac origin, health violate coronary vessels, contraindications, low blood pressure, or taking medication for erectile dysfunction, Viagra, Levitra, Cialis, or similar. So before you assist a male patient with nitroglycerin, you need to ask, have you taken any medications for erectile dysfunction? Thank you. The last word, it's important, or I guess you need to relay to him. It's important that I know because I'm about to give you medication, and if you did, it can have an adverse side effect and drop your blood pressure. Could send you into cardiac arrest. Typically, it doesn't. And what all these medications are is they operate just like nitro. They actually, whenever they were studying them, they're actually just more drugs that work like nitro. And they found out that it had this wonderful side effect that could be work for erectile dysfunction. And so that's what they're used for now. So side effect is dropping blood pressure. So epinephrine auto-injector. There is finally a generic of the auto-injector. The only problem with it is it only costs about $30 cheaper than the freaking ridiculously priced EpiPen. So an EpiPen auto-injector can reverse severe allergic reaction, and it also can help with an asthma attack. You guys are in Oklahoma anyway, allowed to give it for either of those etiologies. So prescribed and used for patients with severe allergic reactions, classified as anaphylaxis. And vasoconstrictor relaxes smooth muscles and airway passages. Side effects: increased heart rate and blood pressure. They will also have jitteriness. I don't know who's had a shot of epinephrine here or adrenaline. If you have, it's nothing like if you get a shot for highs or whatever. I had it before, and I was trying to eat a cracker, and it's hard to hold the cracker and eat because it's like you're just ready to go. So much that you're shaking. So. Narcan, other drugs that may sometimes be administered. Narcan or naloxone, antidote for a patient who's unconscious and in respiratory failure after taking a narcotic. Does not work if patient has not had a narcotic. So if they're on a benzo like Valium or Ativan, Narcan is really not going to work for that. You need something like Romazicon, way above you guys. So don't worry about it, but just know that it has to be a narcotic medication. This is where pupils will kind of save your day. You come in, you freak out because the patient's unresponsive. You don't know what's going on. They're breathing 4 times a minute. You think, oh my gosh, this person's getting ready to die. You look at their pupils and their pinpoint, and you're like, oh, just most likely just overdose. No big deal, right? And so you guys bust out your Narcan with your nasal atomizer, and you squirt it in their nose, and they come away. I will tell you on the Narcan, basically, there's a really good chance that if you push it too fast, they're going to come awake and they're going to vomit. Push it, if you can push it nice and easy, and you can push it to a point where they just start breathing again, that's good. Don't fast push it. Medics are really, this is a terrible thing to do as a paramedic, but the medics are known to do this. So they'll show up at an ER, they'll have an IV going, they'll have an overdose patient, they bag all the way to the ER, and I don't know if they do this anymore. Probably it'd be a good way to get a lawsuit from if the patient asks for it. But then as they're wheeling in, they'll fast push the Narcan so that once they get into the ER, the patient vomits. Not cool, right? Not cool, right, Ellen? And then you got a fighting patient. I've always heard that, it's because you ruined their high. But the thing is you get this reaction from every single narcotic overdose that you run. whether it is an accidental narcotic overdose or a heroin overdose. Not, and all of them are accidental, right? Nobody wants, except for suicide. But I had an old man who he was probably 80. He went to the ER. They overdosed him on a narcotic medication. I think it was Demerol, but I'm not going to. I wouldn't testify to that. It was several years ago. And so, as a new medic, I'm like, oh, I'll just wake him up. No big deal. Because they sent him home, and then the med hit him, and I mean, he was out. And so I slow pushed the Narcan, woke him up, and as I woke him up, he was ready to fight. And so right then it told me, well, and they're confused. And right then it told me that it wasn't that they're mad that you ruined their high. They're really confused about what the hell is going on. I mean, have you ever been startled out of sleep? This is startled out of sleep times 10, and they're confused. It takes him a little bit. He was gonna whip. He told me he's gonna whip my ass for stealing his money off of his nightstand, and I'm like, you're in the back of an ambulance. He goes, no, I'm not. Damn it, I know where I'm at. Just look around. And it took him a little time, and finally I could see when the lights came on and he was home again, and he's like, I'm in an ambulance. Ain't I? Yeah, you're in an ambulance. And so it wasn't a matter of being angry for ruining his high. It was a confusion, and so they all go through it. And so we had one out here. We woke her up, and she it was an accidental, and she fought us, and I think she fought you guys in the ER until they were able to get it fully reversed and got on top of it, and she finally come around. But it's a confusion more than being angry. So if anybody ever tells you that they're fighting because they're angry, then crazy druggies, it's not. It's a confusion. To me, it really mimics a post-ictal patient, a patient that just came out of a seizure that's coming around. Oh man, try to get too close to them patients, and they don't like it. They're confused. They don't know what's really going on. It takes them a little while to clear the cobwebs out, but you can always see. It's weird. You can always see whenever all of a sudden they realize, oh, I'm back. And you're like, oh, that's over. So.
My mom had really seizures like that, and like for the first 20 minutes, she just let it be. Mm-hmm. And then my white one, she would just look at her and say, "Oh, you're back."
Yep.
It's nice to see you. Sometimes she would be really mean, and sometimes she would be really, really emotional.
Yeah.
We would just sit and cry, and she goes, "What's all that about?"
See, our treatment has always been give them oxygen to help them come around quicker. Well, good luck getting close enough to that seizure patient to put oxygen on them because they don't want you close to them. They're scared. They don't know what's going on. And I've chased a kid around the yard in Wichita with an oxygen. Hey man, just come on here. And finally got him to come around. But it's one of those things that we had to stay with him because he's outside, and we really wanted him to come around because he's outside. And so it was probably very entertaining for the neighbors. But force protection medication, so atropine auto-injector to treat responders in the event of an attack. We don't have this, even though I've looked at it. They have different things for different types of attacks. One of them is called a duodope, so it has two different kinds of medications in it. But some of them have large amounts of atropine just in case there's an organophosphate poisoning. And that's what I wanted to go with was the large amounts of atropine for the organophosphate poison. Not because I think that we're going to have some large terrorist attack out here in Roger Mills County, but you see these big spray rigs driving around that are spraying on these crops. Sometimes they're full of organophosphates. And so what happens whenever we have some sort of accident with this that we get into before we realize it, or we're trying to help a person out? We don't have enough atropine on a truck to reverse an organophosphate poison. Okay. Is there?
No, it's about one of our gymnastics pregnancy, exercise on that.
Oh, okay. They're wanting us to do exercise all the time now?
I guess.
Jeez.
And I don't understand what we're supposed to do because it doesn't give
So, anyway, right now we don't have any, but understand that you may end up, if you work in EMS at all, you may end up in a service, or we may end up getting it at a time. And all it is just like an auto injector. One thing I can tell you about auto injectors, don't put your thumb at one end whenever you go to give it. Hold your auto injector with both ends sticking out, so that if whenever you go down to give it into your thigh, you accidentally got it turned around because you're blinded by the organophosphate, that you don't shoot it into your thumb. Yeah, ow. And now I'm dead because I don't get the medication. Where it's going to be effective. Your thumb really not going to reverse anything.
So,
Try again.
the book says that you typically give it to yourself and your partner.
Yes.
You do, but going to see who's going to do it.
Well, it's okay. You mean who's going to do the injection?
That's what it is, yeah. It says typically you would administer the medication to yourself and your partner.
Yeah, I mean, okay, if your partner's unable to administer their own, then I would say that would. But I'm hoping that we're going to be administering our own medications. You know, all it is, auto-injector inside of it hurts like hell. But if your partner is incapacitated, you then need to give it to your partner. And that medication is for you and your partner. Sedgwick County, we carried 3, just in case there was a student with us. You got some cheese fries for me? No?
Turn the light on and shut the door, please.
And so, but yeah, if your partner's incapacitated, yeah, give it to him. I'm not going to play the video. General information about medications. Each drug is listed by its generic name. Each drug has at least 3 names: chemical name, generic name, and brand name. All 3. One or more trade names given to the drug by manufacturers. So you might have 5 different medications that go by a different trade or brand name or trade name, but they should have the same generic name, and they will have the same chemical name. Now sometimes they get tricky and they switch an isomer, and all of a sudden they'll give it a completely new name, even though it's the same dang drug. Just mirror image. Just fact for you. Mo money. What happens is after that patent runs out after 7 years, they come out with the L isomer of it. So basically, it's just a mirror image where they change a position of a group, and so then there's not all the research and development. And they know it's going to work, and then they get a patent for another 7 years. What you need to know when giving medications: indications, contraindications, side effects, and toward effects. So indications. That's what the medication is given for, right? This is why we're given the medication. Don't give a medication that you guys should never give a medication that it's not indicated for this disease process. If a physician wants to do that, I think they're not supposed to either, but I don't know their boards. That's up to them. But we have to actually use it as an indicated for what it's indicated for. Contraindications. This is time that you should absolutely not give the medication. So they'll have their list of contraindications, like aspirin with stomach ulcers. You shouldn't give aspirin. Some of them aren't as severe as others, but they still could cause problems. Side effects. These are things that typically will. Side effects are things that you may see that are kind of normal for this medication. So a side effect of, we talked about albuterol, the jitteriness. That is a normal side effect of albuterol. That's not a untoward effect. An untoward effect is something that you really didn't want to happen. So you gave them the nitroglycerin, and you dropped their blood pressure greater than the 30 points. They may have better examples in the book of untoward effects, but those are basically side effects that you really don't want to happen. They're not real common, and they're actually I guess for lack of a better term, they're bad. An untoward effect is kind of bad for the patient. What do you need to know when giving medication? So, form of the medication: compressed powders or tablets. This is kind of what it's in: liquids, gels, suspensions, fine powder, gases, sublingual sprays. So, my wife always makes fun of me because I think it's suspensions. You don't have to shake them. It's a suspension. It's always there. Should I shake everything that's liquid? Because I don't know. And she makes fun of me. That's fine. So, just in case, exactly. That's what I
It says do not shake.
Gases are like your oxygen or laughing gas, so nitrous oxide. Sublingual sprays are like your nitroglycerin. Fine powders. Trying to think of an example of a fine powder. You know, I'm not sure that. MDI inhalers. That makes sense because that is kind of a real fine misty powder you're inhaling. Gels. This would be like your oral glucose and things like that. Then liquids, and then compressed powders or tablets. So you'd have like an aspirin's a tablet, but also comes in a powder form. If you can find it, it's really good for emergency situations. Administering or assisting with medications is a serious responsibility. Know the medication and use good judgment. They go to the 5 rights. Okay, good deal. Medication authorization, offline medical directions. Do not speak. We already talked about this, I believe. Offline medical directions. You don't speak to a physician. You're using a standing order or a protocol. I highly recommend that you, as the ENT basic, find out what the medications are that you could give as a basic, and read so in our protocols in the back of them, we have what their indications are for, what you could use them for, and which ones you need to get a physician's order. I would know which ones that you need to get a physician's order for, so that you're not calling in talk to the physician on something like aspirin that you could give by standing order. There's no need to bug the ER with that unless something doesn't sit right with you. You always use that doctor as your last. I guess you always put it on them. It's their license. Let them make the call if you're not real sure about it. It's like, so they've had a history of something that doesn't work well with aspirin. You know what? I'm going to call a physician and talk with them and let it be their decision. Online medical direction. Speak directly to a physician. I've already told you guys that. You can't get an order from Ellen or even a mid-level like a PA or a nurse practice. They can relay an order though. She'd say, "This is Ellen. Dr. Eubanks went ahead and confirmed to give such and such stuff." And you want to echo it or repeat it back. What's that, Ellen?
Yes, I'm just thinking. Let me see. Yeah, it's fine.
And ask for clarification if necessary. We talked about the Skittles. You want to give 4 Skittles. They said give a full bag of Skittles. You want to ask for clarification if that order doesn't seem right. The 5 rights. Do I have the right patient? Now, this is when you're assisting with their medication. Obviously, if you're using a medication off your ambulance, it is going to be the right patient for this medication, right? Or it should be. Is it the right time to administer this medication? Are they having chest pain? And that's what the nitroglycerin is prescribed for. Yes, they are. Or, hey, they have nitro, but they're just having toe pain. No, this isn't the right time, correct? Is this the right medication? That's obvious. Is this the right dose? And then, am I giving this medication by the right route of administration? So you take a sublingual nitro, you don't spray it in their ear, it goes under their tongue. All right? It might work in their ear, I don't know. Normal side effect of nitro, speaking of that, is a headache, and you might warn them. On that nitro bottle, you want to prime it I've always primed it into something like a pillowcase, into the sheet of the cot, or something like that. Some people will prime it in the air. You know, yeah, you breathe it in, you end up with a headache, or even worse, you're sensitive to it, and you end up on the floor of your ambulance because you passed out. That wouldn't be good. Prime it into something. Get in the habit of doing it. I see people just spray it in the air all the time. Like, yeah, what are you doing? Prime it into that. But you do want to prime it before you give a medication because it is a metered dose. So you want to make sure that it's going to give the correct dose. So think about it. What would be the potential risk to the patient if each of the 5 rights were not checked prior to administration? It could be a serious consequence, right? I mean, up to death. Exactly. Giving medications isn't something, even the medications you get, even over-the-counter medications, isn't something that should be taken lightly. A medication is only over-the-counter because they have determined that the benefit outweighs the risk of that medication being over-the-counter. So something like aspirin, it's a lot more beneficial to society to have access to that aspirin if needed over the counter than the risk of somebody taking aspirin incorrectly. It has nothing to do with safety. For instance, I think they still have it on the counter, but the take it for overdoses, pour it in a spoon. Syrup of Epicac. Syrup of Epicac was something that was over the counter for years and years and years. The problem with syrup of Epicac is if you don't know how to give it, you have a drunk person give it to their drunk friend to try to make them throw up. And it didn't work the first time because they put a spoonful in and then, oh my gosh, they're not throwing up. Yeah, it's just going to burn away it. But the thing with syrup of Epicac is you have to give it a lot of water. It's not the amount of medication. You give a little of the medication. But if you don't know that and you keep giving the medication, it's cardiotoxic. And so you can't get it anymore. Yeah. But it's just an example that it's not. Definitely. And also can be used as a fecal marker so we know, hey, we're getting to the end of this. So anyway, be careful with medications. It is an important thing that you grasp, have an understanding of the medications you're giving. Not just I know that aspirin's given for chest pain, so read the contraindications, read the indications, read some of the side effects that could happen. Routes of administration, oral or swallowed, sublingual or dissolved under the tongue, inhaled or breathe into lungs, usually as tiny aerosol particles, such as from an inhaler, or as a gas, such as oxygen, intranasal or sprayed into the nostrils. So we're talking about intranasal Narcan. You're starting to see some different medications like intranasal Valium for your seizures and things like that. Intravenous or injected into the vein. Intramuscular or injected into the muscles. Subcutaneous or injected under the skin. So you could give sub-Q epi if you're a paramedic, or you just do IM epi with an auto-injector if you're a patient. Interosseous or injected into the bone marrow cavity, which is really fun. And endotracheal or sprayed directly into the tube inserted into the trachea. They're really going away from endotracheal medications because their effectiveness really isn't all that great. It's hard to determine how effective said dose is, and so it's kind of a last-ditch effort for us. So we're running a code. We couldn't get IV. We don't have IO for whatever crazy reason. And so our only option now is ET, and so that's when we use it. Pharmacodynamics, study of effects of medication on the body. What effects will medication have? How will the medication affect my patient specifically? And patient-specific factors change how medications work. Dialysis patients may not break down certain medications as fast so it stays in your system longer. There's just things like that you kind of, basic medications, there's not many that you guys really have to think about in that depth as you're going through pharmacodynamics. But as a paramedic, there's a lot of times if I give a medication that I'm not like completely familiar with, I will go read pharmacodynamics on the medication. Because I want to know how it's working on the body, and I want to know, is there a reason that I shouldn't give this medication? Let's say that they're in renal failure or liver failure. It's broke down in the liver. Maybe I shouldn't be giving this medication. And so I will go read on that medication if it's a medication I'm not real familiar with. Reassessment and documentation. After administering medication, reassess the patient and clearly document medications administered. Our documentation software make it pretty easy. You select the medication from a list. You put in the dose, the route, and I'm stuck up. And you also, if there was any side effects of the medication, and so you document all that, put right into your chart. It's actually really easy to do. So, medications patients take often. Oh, look at that ad there. Advair is a medication that may be prescribed to a patient for daily management of a respiratory disease. It should not be used for emergency treatment of an acute attack or breathing difficulty. I'm going to focus this in. I'm not going to read all this to you, but I want you guys to kind of get an understanding of what's going on here. So you hear you hear people say, "Oh, just take the horny goat weed. It's natural. It'll work better for you." Or my grandma was real big in the red rye yeast or whatever for blood pressure. Make sure you talk to your doctor and pharmacist that you're taking any herbal type supplement. Not that Jacqueline, if you go down here, Jacqueline's not going to chastise you for it, but sometimes, because what a drug is typically is, hey, we found that this thing works. So they engineer out a lot of bad things. But still side effects, drugs still can be nasty, but so you start taking this drug for this, but also maybe a supplement, and you might be doing yourself real bad thing. And sometimes maybe you're taking one type of herb for something and it'll interact with a medication that you're on. And Jacqueline will go and look at those kind of things where she stays up on it a lot. And she, some pharmacists will tell you that herbs are garbage, and those pharmacists are probably garbage, but she'll tell you that, herbs will work, definitely, but she also will want to know that way she's able to make sure there's no interaction. And so that's something that you guys got to kind of watch. That's something that you guys should watch with your patients too, and maybe relay that. Are you taking any herbal supplements? And question them and get that, because that might be something that's going on with them. Assisting in IV therapy. Yes, please. Setting up an IV fluid administration set. Ways fluids and medications may be administered into the vein. Heparin or a saline lock. You don't see a lot of heparin locks anymore that actually have that they actually lock off with heparin. Do you guys do any heparin locks? Typically, it's in a hospital situation. We just do saline locks, so we'll flush it with saline. But understand there are heparin locks. What a heparin lock does is keeps any blood from clotting into that IV catheter. So you have less of a chance, and into that port. So you have less of a chance of that occluding and then you losing that IV. I think heparin locks are more for your long term. Your patient's gonna have a lot of IV access. They're gonna be in swing bed for a week or something like that, where they're gonna be doing a lot of IV things. Versus us, we have them for 45 minutes. And so what's that?
There's no sense in using that.
Yeah, definitely. So catheter placed into vein, cap or lock placed over into catheter. Lock contains support for administering medications. Another thing that the locks do, so we try to use saline locks here, but what it does is as we show up to the hospital, Roger Mills uses a different IV fluid administration set than Elk City does. Well, we use a different administration set than any of them. And so what happens is we show up to Roger Mills, if we don't have a lock on it, it's going to be a really big mess for them to switch it out, where they're just going to DC or discontinue our IV. Whereas if we have a lock, they just take off the lock, they put their administration set on, it's easy peasy, they can start medications right away, and they will eventually change out our catheter because our catheters also aren't intended for long-term use. And so they'll go ahead and usually, if they're going to keep the patient, they'll go ahead and get their own IV. So.
The nurses argue, the new ones argue, they like the little short ones. When I was a patient in here, they put one of those freaking things in there.
Yeah.
Have the one knot.
Oh, so it moved.
They move, they hurt,
Yeah.
but once it's put that in the wall, what do you think? They stay still.
Yeah.
And I was like, well, yeah, we're gonna start out, you know, you don't wanna put this freaking thing in there, then we're gonna get crap all night, and then we'll see how you like them. They
Yeah.
hurt.
But they're saying are you talking about the blue lock?
Yeah.
Yeah, you know, if there's certain things you do, and one of them is they have like a little foam piece that can ride under it. If you have the right,
Bring me over.
Venagard or whatever. And so anyway, ways fluids and medications may be administered into the vein. So traditional IV bag hangs above patient, constantly flows fluids and medications into the patient. Clear plastic tubing connecting fluid bag to needle catheter. It's called the drop set. Please be aware there is a 10 or a 15 drop set, which is a macro set, and there's a micro set, which is a 60 drop set. All right. So if your nurse or your medic says, "Hey, I need you to get me a drop set," say, "What size, micro or macro?" Because sometimes if we're not paying attention, and let's say you threw me a 60 drop set, I put it in, and I have a trauma patient, that's really not going to do much good for it. Micro drop sets are for things like, let's say, not micro, that's for like nitroglycerin and things, but you're really trying to control that flow rate. You really want to get it precise. And so, anyway, extension sets make it easier to carry out or disrobe patient without pulling out the IV. So probably if they would have put an extension set on Ellen, it may have helped, but they are kind of bulky, the blue ones, and so long period of time that rubbing, moving, it would get to be very painful. So, whenever if you're going to help, you want to inspect the bag to be sure it contains the solution that was ordered. It is clear, it does not leak, and it has not expired, especially at a small service. All right, we try our best to keep all the expireds off and rotate our stock out, but you still can come across an expired bag. Let's say that it's in our trauma bag. We just forgot to look last month, and last month when it expired, most likely it's going to be fine. But anyway, look at it. Now, if you pick up a normal saline and it's cloudy, yeah, probably ought to go ahead and throw that one away. Or if you squeeze the bag and it has a leak, get rid of it. So here's an administration set. I can't really see. It looks like a macro because it doesn't have a little needle inside the drip chamber. The patient or that person in their right hand, that's what you spike the bag with, and that's also the drip chamber. The drip chamber, depending on what you're doing, so typically if I'm going to count drops, I like it half full. If I'm going to have it on a pump in the back of a moving ambulance or aircraft, we'll just fill that drip chamber all the way up because it's on a pump, and that gives a less chance of getting an air bubble in it. And then what that air bubble does is makes a stupid pump alarm. It's annoying. Please don't freak out over air bubbles. I had somebody rip an IV out of somebody one time because they seen a few air bubbles coming through. They're like, "You're gonna kill him." They're like, "Hey, don't ever rip my IV out again. I will kill you." That's death for you. But it would take that whole tubing of air to give them an air embolus. All right. So seeing a few bubbles come through, don't rip the IV out. Don't freak out. I don't know if you guys have ever heard that before. If it has any air in there, you'll kill them. Not unless they're circle and drain anyway. There you are, spike in a bag. Insert the spiked end of the tubing into the fluid bag. Guys, be careful whenever you you're going to take a cap off of your bag. Don't touch around where that spike's going to go. And when you take the spike off, don't touch that spike. Work it in there without touching either end. All right. You don't want to contaminate it. You don't want to cause some sort of nasty infection, which happens. So I always run and it looks like they have it up as high as they could go. I always run my drip chamber before I even hook it up to the bag all the way to the top, and I'll shut it down. The reason I do that is so that I have it right here, and I'm not, whenever I go and start filling the bag, I'm like, oh crap, it's all the way down there. And then it's harder for me to control. And so I like my roller clamp all the way up by the drip chamber. That way I have it shut off, I spike my bag, I do a couple of squeezes, it's halfway full. The roller clamp's right there, I open it up, now I can watch it go through, comes out the end, I shut it down, I'm ready to start my IV. There's the roller clamp. So maintaining an IV, troubleshoot flow problems, constricting bands left in place by mistake. Sometimes if you go to start an IV, man, they got good flash, they turn it on, they're like, what the hell, it's not running. And the shirt came down and fell over the tourniquet. That's a constricting band left in place. So try to make sure that the constricting band is removed. Sometimes you have a really good IV and you have it running good, and then you look over and you're, oh crap, and you'd left the tourniquet on and their hands turning purple. But somehow you still have good flow. Flow regulator left closed, so if you don't have any flow, they had it all the way shut down. Whoops. Clamp closed on tubing. So all of them have a little clamp, a slider clamp, and it just slides over the tubing and shuts the tubing down. And line pinched under backboard, and this is in trauma, or line pinched anywhere. Follow your line out to see and make sure it's not pinched off or kinked if you don't have flow before you go and take it out. Adjust flow rate properly and then monitor IV sites for infiltration. You guys, I don't believe, are allowed to adjust flow rate. You can, however, transport a patient with an IV. The only thing that you really can do with that IV is watch it drip at the flow rate that the sending facility set it at, and this is just normal saline, it's not a medication, or you could shut it down. Those are the only things you could do with it. You can't adjust the flow rate, okay? So, chapter review. Aspirin or oral glucose and nausea are medications carried on the ambulance that that the EMT may administer to a patient under specific conditions. Aspirin, oral glucose, and oxygen. Okay, I'm gonna make sure that they didn't say nitrogen. Prescribed inhalers, nitroglycerin, and epinephrine, and autoinjectors are medications that, if prescribed, the EMT may assist the patient in taking. Guys, you can, in Oklahoma, you can move epinephrine autoinjectors, nasal Narcan, activated charcoal, nasal, and albuterol and Atrovent, you can move those all up to those are medications you guys are allowed to give. You may be able to administer intranasal Narcan or encounter patients who have received it from a layperson. Yes, it's over the counter now. So all your heroin addicts can push that envelope as high or low as they can. Their buddies will bring them back. You may need to have permission from medical direction to administer or assist the patient with a medication. Follow local protocol. That's the important statement there. Follow local protocol. Don't assume because it's one way at one service, it's going to be the same way at another service. Our service has the same set of protocols as like Leedy because we both adopted the state protocol. There is a wide variety of medications that a patient may be taking. You'll try to find out what medications the patient is taking when you take the sample history. These drugs may be identified by a variety of generic and trade names. Get the list of medications, even if you don't know what they are. It'll help the hospital out. Your main purpose in finding out what medication the patient is taking is to report this information to your medical director or hospital personnel. So if you're going to give a medication, you probably want to know what medications they're on so you can let the medical director know so he can make an informed decision on the event. EMTs administer aspirin, oral glucose, and oxygen as part of patient care. EMTs may assist with prescribed inhalers, nitroglycerin, epinephrine autoinjectors, blah, blah, blah. EMTs should understand the names, indications, contraindications, and side effects of medications that they intend to administer. EMTs must have appropriate authorization to give a drug and always must follow the 5 rights of medication administration. Reassessment and documentation are important elements of medication administration. Should I administer a medication? Yeah, it's a good question. Should you? Yeah, if it's the right situation. I wish what I'm trying to get at there is I wish that my EMTs would ask themselves more, should I give a medication? Because they come across a lot of patients that they give medication to, but it's a comfort level. It's a scary thing to do until you do it. And so they don't want to do it. And so I wish that they'd ask themselves that more. How can I get more information about a drug? I use Epocrates on my phone. It's fast, it's easy, it's a free resource, and I'll tell you how good of a resource it is. A lot of pharmacists and doctors use it. There's actually a paid version that gives them all kinds of information that we don't need, but the free version will give you anything and everything that you could ever want. You can even run interaction. You can also check for interactions between drugs. You can also identify medications on that with. You start putting in what it is, like oblong, what color it is, and all of a sudden you might be able to find out what medication they have. So I love Epocrates. There's other ways. You could have a nursing drug handbook on an ambulance. Ambulances used to always carry a big old nasty nursing drug handbook. So whenever we're running, we could. Yeah, that is a physician desk reference. It's a big text.
Skinny now.
Oh, is it?
It went from this big to that big now.
Huh. So anyway, there's all kinds of different text apps and things like that. I recommend Epocrates. What are the necessary steps that must occur after medication administration? You guys know? Reassess your patient, all right? So, a patient is complaining of chest pain. Here's some nitroglycerin, says a family member. Give him that. What do you do? Yeah, use your 5 rights, right? Guys, I'm sure we've all done it.
Never.
Taking spouses or somebody else's medication. My wife's a pharmacist, and we do it at her house. Like when I got hit by the deer and I couldn't freaking walk, she's like, "Here, take a muscle relaxer." I don't have a prescription. I probably shouldn't say that in right? But
I've never done that.
yeah, right.
Never. Put me down as that.
Neither has Jacqueline. I stole it. So, but anyway, but you'd be amazed at how many families share some serious medications. Like, oh, I had high blood pressure, so I took some of my wife's blood pressure medication. What? That's pretty serious. So yes, please use your 5 rights.
Maybe an antibiotic or
Yeah.
something.
Man, people are crazy with that. Anti-psych med. He's having episodes. So I gave him some of my. It's like what? I gave him some of my lithium. I got a bloody nose right now. So I actually had the whole lithium story. Lithium, you're supposed to take a medication that counters the extrapyramidal effect. So lithium does things. It's not really an allergic reaction, but it'll do things like swell your tongue up or paralyze your face. Or they're called an extrapyramidal effect. And sometimes you could take a medication to counter that. So with lithium, the medication is cogentin. So we go downtown Wichita, and this guy, I mean, his tongue was falling out of his mouth. And I mean, it is huge. I'm just laughing. You can't understand him. And his wife's like, he was going crazy. So I gave him some of my lithium. Did you give him the cogentin with it? Well, I don't get that. Okay. So, she didn't have the extrapyramidal effect, so she didn't have to have the cogentin, but it's a medication that usually goes hand in hand, and the cogentin will make you tired. But yeah, he needed it if he was going to take her psych meds. So we gave him a whole bunch of Benadryl. Is not a whole bunch, but we gave him Benadryl. Got reduced the size of his tongue, or he could actually start talking. But it'll do other things too, like cramp him up and all kinds of things. Take a 10-minute break. I'm gonna get this other one started. Maybe get this bloody nose to stop. Doesn't stay light until about 8:30 ish. I'll get started in. I'll at least get started into the other one. Oh man.
Oh, now that boy better not will turn his phone off.
I have beef jerky, all I have beef jerky and M&M's.
Kristen, mate, you turning your cell phone off?
I've had a peanut butter toast today.
All I have is beef jerky.
He either turned his phone off or he played it with the battery ran out. Hello, baby.
Was that your sandwich to eat?
Not even.
So it give it to you? The freezer gave it to you?
Hey, well, I can't do anything. You got the bathroom door locked, Giver. Mom, you gotta open the door. Are you done?
You're sick.
I'm gonna get sick. Why would I get sick?
Papa?
You didn't talk about the baby? I think I'm immune to all symptoms. Knock on wood.
I remind you that.
I mean, I don't know. Good Lord. I don't know what it is. And I'm not saying this, honestly, my immune system is freaking awesome. Cause when my kids are stuff sick and stressed and all of this and that,
Let's go see breakfast.
I never ever get rid of it.
What did you play?
Probably. And And down there in that laundry with all those dirty clothes and stuff.
I'm
That's where all the
taking bubbles.
Can I take some bubbles?
You want some bubbles?
I trade you bubbles for cheese fries.
Not with cheese,
No, I tried calling and it went straight voicemail.
Well, I was doing practice.
Well, I just called like a few minutes ago.
Well,
Is your phone on?
yeah,
Okay.
I don't say that I have a call. Can I? Use this pen.
Get your butter cheese fries.
See what it says? What? Your ears? Those are bed bubbles, huh?
Let me do that one.
Here.
Yeah, that's what I'm talking about.
Have fun.
Well, that's a huge cheese fry. Ow.
Yeah, it's gonna last long in my house. Okay.
Well, these are big. Oh, these are big cheese fries.
You're welcome.
No,
You know these vehicles are spicy.
You're done.
it's, yeah.
All right, go, go. We're done. All right, that's pretty good. All right, go. Bye.
Can I put the biscuits for me at home?
I don't care.
Thank you.
Uh,
After
yeah, go ahead.
all,
Pick something for sugar. Got it?
Yep. One problem. You open all the doors.
Yeah.
Okay, my glove.
They don't like 4th of July then?
Glove.
You don't like 4th of July then?
Yeah.
Yeah?
Yeah.
Then that's not a dead body.
Or are you a communist?
Person, how'd you tell me to be quiet?
I've heard- I've heard too many people going deaf and having trouble with their ears. Because I shoot guns and I never used to be big on the earplug thing, but now I'm like, I don't want to lose my hearing. And it's like, we got.
Earplugs and shoot guns. You're crazy if you don't use ear protector shooting guns.
I never used to. I do now and I make my kids. We shot clay pigeons yesterday.
Yeah.
I didn't have them and I was like, oh. But I knew Cutter wouldn't shoot very much. 8 or 9. I threw, I think, 5 pigeons and shot 3 times and then shot 2 times. 8 or 9 pigeons.
Sunset?
But I don't think about WebEOC. I don't know, and I bring off all the crap. So I don't know how if they're gonna call. If we're supposed to be. That's what I thought. From Bill Presley.
No people confuse the shit out of me. All I do is talk an acronym.
Yes. Because do you have any SMS policies? What in the heck is SMS?
S&M policies? No, we don't, we typically don't promote S&M here at work. No, we don't promote our people do it at home.
Oh.
That was funny, you were at the board on Sunday. And this little boy, they're like, can you tell if his arm is dislocated in his elbow? Cause they were all doing all this stuff, and they're like, I ain't saying either. And my ex-husband's girlfriend is paramedic. I said, go down there and ask her and see what she says. And she goes, oh, I don't think it's dislocated, but I think it might be fractured. And I was like, didn't we learn that one thing is dislocated isn't fractured? I was like, that was totally opposite of what we just learned. And I was like, I thought most likely I said, I bet it's not great. I said, easy, I just dislocated it. If not, just swollen, bleeding. You know, I said, I don't think it's broke. I mean, if it was my kid, I wouldn't think it was broke. Cutter, he's got a big old, he got stepped on right where his vest doesn't, you know, let one of your arm. He's got a big old honk in.
Years later.
But it, I mean, it's even swole up. I mean, like it's down here on the bottom, right where, and up in his armpit, it's bruised real bad. But he got stepped on right, I mean, it's right where your vest doesn't cover. Ripped his shirt, his shirt. He wanted those. My kid got stepped on this weekend.
Oh, really?
I wasn't there.
I told you one time I was hurt, I said, "See, so, it was broke, I guess."
Dang. Yeah, where do you get this one from?
There's three places, I don't know what to tell you.
That's what I tell him now. The ex-husband's girlfriend, the paramedic, and the other kid got banged up pretty good. And then some of my friends got up next to the front and said, "Can you tell if his arm is dislocated?" And I said, "Man, I can't say that." And I said, so I said, "Go out to that lady down there to the paramedic." And she told me, "No, it's probably fractured, not dislocated." And I was like, "Isn't that what we just did? It's probably dislocated instead of broke."
Where's your brother?
It's not just swollen.
Before we
I didn't say anything. I was like, I just wanted to see what she said. She's paramedic. And I just wanted to see.
That'll cost you another whipple. I guess I'll use it. You want to eat that, Reed? That's a yes. I'll order you some.
Hey, I'm just not eating a whole lot anyway. I'm on the factory on my head. Eat it all up.
You just stopped at another one, I guess.
I don't think they
I would take all of them. I got to write steer in on June 3rd, July 30th.
Oh, it's just right for common act.
I don't even have comments on that, so I'm gonna start with them.
I told you.
I have one to go and I have my thing under the
All right. What time does it end? Sunlight? 25 minutes. All right. We have about 15 minutes of class left. So let's get into it. So chapter 17, respiratory emergencies. Kind of let you guys know, after we finish respiratory and cardiac, we will do our CPR. That way, for those who aren't, will become CPR certified. Probably just renew yours. I don't know when you're up, but you should do it anyway. So, all right. Respiratory, I'll give everybody a heads up before that happens. Though. I don't know. Does it say on the thing?
I don't know what you want.
Me either.
I don't know what it's gonna be.
Oh, I have a printer.
The 26th, I'm going to tell me. I think I'm being very, that thing if we do.
If we have class, and I'll get it, I think it's like May 13th. I'm actually going to the USC fights in Dallas, so I won't be here.
Oh, man.
So for rodeo, balls are warm by Saturday.
I won't be in Monday. Next Monday.
That's not playing, so, oh, what's that? That's creepy looking. Yeah, I'm gonna, last view, okay. Last preview. What the heck? What's this doing? Go back. All right. Try again. So, the prescribed inhaler. What, really?
I don't know where you're at. Get away from your skeleton.
The respiration and that physiology or
Oh, we're all the way in slide 83 there. There we go. Respiration. I hate when that thing, like, you hit a video and it jumped, like, to the video later in the chapter where there's
Go. Now.
the respiration. Respiratory anatomy and physiology. We've already gone over these things. So just a refresher. Diaphragm is a muscular structure that separates the chest cavity from the abdominal cavity. During normal respiratory cycle, diaphragm and other parts of the body work together to inhale and exhale. Remember, you create negative pressure to inhale, you relax. Exhaling is passive. So you actually, the diaphragm pulls down, muscles pull out, causing that negative pressure. Air rushes in, relax, the muscles or the chest goes back to normal. Diaphragm comes up, pushes the air out. Something to think about. I don't know if they'll go over this or not, but sometimes when your patients are, like, let's say, have a penetrating injury, just right about where the diaphragm is, you would imagine diaphragm being. You have to think there's a possibility that they either got into their guts or they got into their organs, because above the diaphragm is organs, below it's the guts, and as depends on what part of inhalation or exhalation they're in, on what parts were hit by the penetrating injury. Inspiration is an active process used muscles contraction to increase size of chest cavity, creating a negative pressure. Intercostal muscles and diaphragm contract. Diaphragm lowers, ribs move upward and outward. Air is pulled into lungs by a negative pressure. Expiration is a passive process. Rib muscles and diaphragm relax, size of chest cavity decreases, air flows out of lungs. Breathing sufficient to support life. Signs: no obvious distress, ability to speak in full sentences without having to catch his breath or their breath. Normal color, mental status, and orientation. May be determined by observing rate, rhythm, and quality. So 12 to 20 breaths a minute would be normal rate for an adult, 15 to 30 for a child, and 25 to 50 for an infant. And that's normal. Rhythm usually regular. Breath sounds normally present and equal. When breathing is not sufficient to support life, signs are rate of abnormal, rate out of normal range. Sorry. And they talk about serious being below 10 and above 28. Right? That's what it was, 10.
Yeah.
Below 10 and above 28. 28. Pretty sure. Anybody confirm? 49. So rate out of normal range. Irregular rhythm. We talked about the different, like the Shane Stokes pattern. Do they actually go into the different rhythm patterns with you guys? Like Kussmaul respirations and all these cool things. Okay, if they don't, cool, because it's okay. Agonal breathing is also called like guppy breathing. It looks like a fish out of water breathing. That. So just remember that. You walk in, you see somebody doing that. They're not breathing adequately. It's not adequate to sustain life. But diminished or absent lung sounds, and then poor tidal volume. So poor tidal volume, an example would be shallow breaths. You just see them taking very shallow breaths. Now, understand that whenever somebody's is in a relaxed state, not respiratory distress, sleeping, it may appear that it's a low tidal volume, but it's not. Okay, you have very rhythmic breaths, equal rise and drop of the chest as they're breathing. And sometimes it's a real, very hard to notice rise and drop. So don't freak out just because you see that. Structure of an infant and child's airway differs from that of an adult. Smaller airway, easily obstructed. Proportionally larger tongue. Smaller, softer, more flexible trachea. Less developed, less rigid cricoid cartilage. And then heavy dependence on diaphragm for respiration. Signs of inadequate breathing in infants and children. You have nasal flaring, grunting, seesaw breathing, and retraction. Do they give you an example of seesaw breathing in the book? Okay. Remind me whenever we come back. I'll see if I can find a YouTube video on seesaw breathing. But I want to show you guys a video of a flail chest or paradoxical chest movement. Inadequate breathing, assisted ventilation with supplemental oxygen, pocket face mask with supplemental oxygen, and then 2 respiratory bag valve masks with supplemental oxygen. As an EMT on an ambulance, the last one is probably what you will do versus the pocket face mask. Flow restricted oxygen powered ventilation device, FROPVD. We don't use it here. I have one. I showed you that. FROP. I don't know where it is right now. And then 1 respiratory bag valve mask with supplemental oxygen. Chest rise and fall should be visible with each breath. Adequate artificial ventilation rates, 12 breaths per minute for adults and 20 breaths per minute for infants and children. Increasing pulse rate can indicate inadequate artificial ventilation in adults. Use entitled CO2 if you're bagging in. Decreasing pulse rates can indicate inadequate artificial ventilation in pediatric patients. Opposite direction there, right? So what's going on? Why is the adult heart rate speeding up? Yeah, so it's trying to get rid of that waste, trying to take on oxygen, and so the body's natural thing to do is speed up the heart rate, also speed up respiration, and that way it can carry the oxygen. Children, decreasing pulse rates can indicate inadequate artificial ventilation in pediatric patients. I'm not exactly sure why it's decreased. Maybe the book tells you. Do they? My guess is so basically it says the exact same freaking thing. It's the exact same freaking thing as adults. An adult patient, if left untreated, will go into slow breathing. They get tired. Yeah, and then it progresses into cardiac arrest. You're right. So think about it. How might you recognize the progression from adequate breathing to inadequate breathing in the assessment of your patient? Real easy. Count your respiratory rate, right? Count it. And watch them take a breath. Is it a normal rate and rhythm? Great. Another thing it uses is pulse oximetry. waveform capnography. Those will all help you. How might your patient change during this transition? Oh, so how might you recognize the progression from adequate breathing to inadequate? So you go from a regular respiratory rate to an increased respiratory rate, right? Yeah, mental status change. Yes, definitely. Maybe a little bit of cyanosis around the lips. So, all those things we talked about. So how might your patient change during this transition? We just talked about it. All right, we'll come back to breathing difficulty. All right, I'm going to get on the road. I have.
Yeah.
So. Let me stop this here.
I'll leave that door open. Thank you.
I guess I already did stop it. I think. Oh, here we go. All right. So, guys, I had a tail light break, and so I wouldn't have any tail lights on my motorcycle. I think we got far enough where we could finish this chapter on Thursday. So I'm going to take off so I don't get ran over on Highway 6. Any questions before I go?
No, I'm good.
All right. I'll try to tomorrow. I'll try to get everybody emailed kind of what we're going to look at, I want to look at doing for the next 2 weeks.
Okay.
Good gauge where we're going to try to be. So. All right. Have a good night.
All right.
Bye.